Hello, my name is Dr. Chigozaram Ikeke. I'm a cardiothoracic surgeon at the University of Michigan. I'm an assistant professor. A lot of things go through my mind when I present with this case, whether it's in the outpatient setting or in the inpatient setting. And so when I see the patient, the first thing I want to look at are their vital signs, assess their clinical status just by appearance. When the patient is endorsing shortness of breath, I want to look at the vitals, the heart rate, the respiratory rate, the blood pressure, okay? And one thing I want to ask the patient about not only the symptoms and their medical and surgical history, but also have they had any intervention in the past for this effusion? Have they had an effusion before? And if so, when? Have they had any interventions, chest tubes, thoracentesis? Have they had effusion on the opposite side? Have they had any recent surgeries? So you want to start off very, very broad before honing in on the cancer and the pneumonia diagnosis. So previous surgeries, previous cancer diagnoses, previous interventions, recent hospitalization, other symptoms, URI symptoms, weight loss, night sweats, and also you want to do a thorough examination, looking for any concerns as far as previous trauma or skin infections or the like. So after ascertaining those details, when I look at the radiograph, not only do I look at the most current or present x-ray, but I want to look at the previous films, old x-rays, old CT scans, or at the time of her breast cancer diagnosis, or if she's had any previous infections. So if all that checks out, I will have her undergo a thoracentesis. And the surgeon can do that, or you can have them sent to the radiologist to do that. Now that depends on the acuity of the patient. If she's having dyspnea, she's sitting in the low 90s on room air, or she needs supplemental oxygen, if her heart rate's up, her blood pressure is not too great, I would prefer to do it at the bedside in the emergency room, right? You don't want to wait for these patients to deteriorate or develop tension physiology for doing this. So I would proceed with inserting a 14 French chest tube. This will accomplish multiple things. One is diagnostic. You can send the fluid off for tests. So you do Lights criteria, looking at the fluid for studies, assessing pH, glucose content. Depending on their surgical history for amylase, if they had a recent esophagectomy, if you're concerned with pancreatitis, I'll look at the protein as well as the albumin level and the LDH as well. Okay, and also we want to make sure that the serum blood work, BNP, CBC, also includes a serum protein, serum albumin, and serum LDH as well to do the Lights criteria ratio. So getting the diagnostic data is important, and also it's therapeutic. A lot of patients do feel better after draining an effusion. You have to be very, very careful about how much you drain. And so usually, if you look at the film, by the time you see fluid on the film, it's about 500 cc's already in the chest. So if it's a large effusion, usually I cap off at 1 liter at the time of implantation of the tube. Because if you drain too quickly in a short amount of time, they can develop re-expansion and demon get very, very sick. So if I place a chest tube under ultrasound guidance, using cellular technique, and I make sure that you give them very, very generous local anesthetic, place the tube in, put it to suction, if it drains a liter, cap it off, and usually wait till the following morning to drain additional fluid. Now, while that's been done, when I look at the Pleural studies, I look at the Lights criteria that allows you to know is it transudative, is it exudative, okay? And as you know, the formal Lights criteria is the Pleural LDH to serum LDH ratio, greater than, I think, 2/3, or if the LDH is greater than 2/3 of the normal, that's positive for exudative. If the pleural protein to serum protein ratio is greater than 1/2, that's concerning for exudative. And also, use your eyes, right? What color is the fluid? Is it murky brown? Does it smell bad, right? Is it gross red? Is it black? Is it green? So, also just use your senses, the smell, your eyes, because sometimes the color alone can give it away. If you see a very murky, yellow, thick, green fluid that smells bad, you're concerned about empyema, right? And so you can wait for the right criteria to be accomplished, but based off what you see that it's concerning for an infection. So let's say it comes back seriously greenish fluid, and you do your Leitch criteria. You also send off the fluid for cytology. 50% of pleural effusions can be positive for cancer. Now, you can have a cancer diagnosis and have a negative cytology. So you also have to keep that in mind. A lot of patients who present with pleural effusions, that's malignant, that could be the only presentation for cancer, despite any diagnosis of no cancer. So that's something to keep in mind. In this case, this patient had previous breast cancer and then pneumonia. So I'm thinking, is this a malignant pleural effusion or is this an empyema? So looking at the pH, if the pH is below 7.3, a low glucose count, those are indications of infections, but even cancer at times. And that's where the color helps. If it's a little murky yellow, empyema is more likely, right? So if the empyema is more likely based on the labs and the clinical observation and the white count, then you want to do a repeat CT scan, see if there's a need for her to have a form of decortication, or there's an indication for TPA. And that depends on how the patient looks, their clinical background, their ability to tolerate surgery, and their protoplasm, if you will. Now, let's scale back. Let's say it's cancer. It comes back positive for adenocarcinoma, or it comes back positive for her breast cancer primary. Different strategy. We have a chest tube in place. So I'll talk to the patient and say, hey, we have the chest tube in place, the fluids are drained out, this is positive for cancer, there's different ways we can go about doing this. And this is very much a patient-led discussion, because a lot of it depends on how the patient wants to take care of these issues in the future and how they want to deal with in the current state. If the fluid is completely evacuated and they do well, I advise the patient, if this comes back, some of the options are as follows. We can put the chest tube back in and go through this whole episode again. We put the tube in, drain the fluid out, and the fluid is resolved temporarily. We could drain the fluid, and if the lung is nicely re-expanded, we can do a pleural desis chemically, where you put tetracycline, doxycycline in the pleural space and promote an inflammatory and scar with the visceral part of pleura and promote adhesion within the pleural space to reduce fluid reaccumulation and any tension physiology from if fluid does come back. Again, the success rate is pretty variable, anywhere from 50 to 75% success rate for that particular diagnosis. Now, if you go to the other options, which may include a indwelling pleural catheter, you have to have fluid for that to happen. So if fluid comes back, you can propose, hey, we could put in an indwelling pleural catheter. That allows the patient to have more autonomy over their care. It will minimize frequent readmissions, and it's also, some patients would say it's a better quality of life for them. Now, it means they will have a prosthetic in them, and it has to be cared for. Infection risk is a serious issue, and it's a procedure. Usually done on sedation or anesthesia in the outpatient, or sometimes in the inpatient setting. So that's also an option that should be discussed, but it's an option as well. Another option is thoracentesis. They don't want a tube. They don't want an indwelling pleural catheter. Just put a needle in, drain the fluid out as needed, and some patients are just okay with that. But you have to measure that with the risk of reintroducing infection every time you put a new needle in and drain that fluid out. And obviously any traumatic injuries with putting in a needle to drain the fluid. So those are the different options to look at for patients with that kind of disease process. Going back to the empyema, again, you can do chest tube drainage, but a lot of patients will need a decortication, whether it's VATS or open. And for some patients, depending on how the nature of the fluid looks like on the scan, a intrapleural TPA is also an option for those patients. So those are the various ways to go about treating pleural effusions. It's very much, it's less algorithmic as much as it is patient-based, based on their presentations, based on their history. A good history is probably the most important portion of taking care of these patients. A good history, but also presenting the different varieties of taking care of the disease process, so that patients have an understanding of what to expect from their care if the effusion comes back, or if it gets worse, or if things change as far as their clinical presentation.